Presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes.
Disclaimer. This video is intended strictly for educational and informational purposes only. It does not constitute medical advice, diagnosis, treatment, or professional consultation. The content is based on simulated or anonymized cases and does not refer to any real individual. Always seek the guidance of a licensed healthcare professional for any personal medical concerns. The creator of this content assumed no liability for the use or misuse of the information presented. Now that we're clear, let's walk through today's case step by step.
Meet our patient, a 12-year-old school-going girl from a lower socioeconomic background. She presents with three main complaints: high-grade intermittent fever for 5 days, migratory joint pain and swelling starting 3 days ago, and palpitations for the past 1 day. Digging deeper into her history, she reports that the fever came on suddenly, wasn't responding to paracetamol, and was accompanied by painful, red, swollen joints, starting from the knees and then involving the elbows. Yesterday, she also began experiencing palpitations along with mild breathlessness. Importantly, she had an untreated sore throat about 3 weeks ago. No prior surgical history or family history of cardiac illness. Her immunizations are up to date, and there's been school absenteeism over the past week. She had self-medicated with over-the-counter paracetamol and has no known allergies. On examination, she's febrile, temperature 102 degrees Fahrenheit, heart rate 112, and BP 98 millimeters of mercury by 60 millimeters of mercury. Her joints are tender and swollen, and there's a macular rash on her trunk. Cardiovascular exam reveals tachycardia with a pansystolic murmur at the apex. The rest of the systems were unremarkable. With the Jones criteria in mind, a provisional diagnosis of acute rheumatic fever with carditis was made. To confirm, we ordered the following investigations. ASO titer, which came out to be greater than 400 Todd units. ESR was 80 millimeters per hour. CRP was positive. ECG showed prolonged PR interval. Echo revealed mild mitral regurgitation. Throat swab culture was sent to confirm prior streptococcal infection. All results aligned with active rheumatic fever. We also ruled out differentials like septic arthritis, juvenile idiopathic arthritis, and infective endocarditis. Thus, the final diagnosis was acute rheumatic fever with cardiac involvement. Treatment was initiated immediately. Bed rest, intramuscular benzathine penicillin, aspirin for inflammation, and prednisolone if carditis worsened. The prognosis is good if treatment continues without interruption. However, there remains a risk of recurrence. She may be referred to a pediatric cardiologist for long-term follow-up and secondary prophylaxis. This case reminds us, a sore throat might seem trivial, but if left untreated, it can echo all the way to the heart.
Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.